Well, now we can admit.
Wonderful. Good morning, good afternoon, and also good evening. I'm in California, so it's good morning for me, but I know within our group today, it's international. So we're representing all the time frames. So good morning, good afternoon, and good evening. My name is Erica Howell, and I'm the executive director of the Cure Blau Syndrome Foundation. I stepped into this role about a year and a half ago from our founder and previous director, Troy Townsend. Troy is still an active board member, so you'll still get to see him. And he's, in fact, just came back from Washington, D.C. from a conference last week. So we still have a great team that's servicing our foundation. Before we begin today's event, I wanted to share with you a little bit of information that might interest you in relation to what our foundation is doing. Especially, I'd like to share how you can get involved if you have interest. Our foundation has started a bio blood bank. It's been around for about 2 years now, and we need more samples. This is a really exciting opportunity because we partnered with Coriell, and one of the main barriers a lot of scientists, researchers encounter is collecting samples and having access to patients with Blau. As a rare disease, we're scattered across the continent and there's not many of us. So there's a lot of challenges in securing those samples. But with a bio blood bank, we are able at no cost to us, submit a blood sample. You're also able to submit a skin biopsy, but that's optional. And the blood bank will store it so that researchers who are vetted and have the appropriate protocols can access these samples. So it's an exciting development as it gives access and it really can further our understanding of Blau and researchers' access to studying Blau. In addition, we have a patient contact list. Some of you might already be familiar with this, but I know we have a lot of new families. And our patient contact list is confidential. And traditionally, we have your email, who in your family is affected by Blau, and the country you're from, and maybe the county or city or state. And it's really great because it allows us to contact you with events, newsletters, volunteer opportunities, research opportunities, and it also allows us to keep a tab on who has Blau around the world. And when we have a new patient that comes to us and says, hey, I'm from Croatia, I don't know of anybody else who has this disease in my country, we're able to look on our patient list and then identify, is there someone that they can connect with? And then we'll contact you. We'd never get out your information and see if that's something you're interested in, kind of connecting with another family, sharing experiences, guiding each other in this process and this journey. Also, please stay on the lookout for some fundraising opportunities. We have led several in the past, and that's allowed us to offer some grants to really fund some of the scientific work investigating Blau. We've been able to be instrumental in Kyoto, Japan, and at the Oregon Health Science University in the United States. Please stay tuned because we have some more opportunities that we are going to be launching soon, and I'm totally excited to share it with you guys. So please just keep in mind, we're going to be having a fundraising campaign that's launching soon. This might be a really great opportunity for family, friends who wanted to support you in your journey to feel like they have a way to do that. And then also, if you want to volunteer, you might have a skill, a profession that you think would assist the foundation, we totally love to hear from you. This is a parent-led organization, and we are doing our best to reach out and make change for our community. So if you think that you have a way that you'd like to get involved or an idea, we'd love to hear from you. Note that on the bottom of this page is our email. So if you're interested in any of those things, you're welcome to email us at Blau Foundation. Our bio blood bank, we have a lot more information on our website under research, and we'll guide you through that process. So feel free to take a look at that. In addition, there's an infographic on the right that talks about how to submit samples for the bio blood bank and what that looks like. More of that on our website though. And then one last thing just to mention is that if you are not following us on social media, please feel free to do so. This is where we post a lot of updates about what the foundation is up to. We give updates on science. We connect you with the researchers. We want to be a bridge from the community world to our researcher scientific world. So a lot of that is going to be housed there. We also want to showcase our Blau community. We love this community, and it's a great way to kind of know who people are and what their stories are. So feel free to follow us on Instagram, Facebook. We're not very active on TikTok, but we just want to have a presence there because we have found some people on TikTok that thought they were the only person in the world with Blau. And once we got on that format, we were able to connect with them. So that is who we are, how you can connect with us. So please take a moment to follow those accounts. All right. Thank you for coming here today. We are so excited about this educational forum. We're examining today the pathogenesis in Blau, and we're also looking at some of those long-term outcomes. Our session will be followed by a question and answer, about 15 minutes of that for Drs. Rose and Drs. Wouters. So if you have questions as we're going along, please feel free to submit those to the chat box. I'm going to apologize ahead of time as I won't be able to get to every question, but seeing as we're a large group and it's a virtual format, if you can submit your questions to the chat box, then when we get to that 15-minute Q&A, it will make it more organized so we can get through as much as possible. So I'll be vetting questions and I, again, would love to get to all of them, but that's probably won't be possible for today. I am definitely excited for you to interact with Dr. Carlos Rose and Dr. Karen Wouters. Some of you might already be familiar with who they are. They are kind of those big names in Blau syndrome. When my daughter was first diagnosed, as you all can relate to, you feel a little bit out of sorts. You don't know who to turn to. You don't know about this disease. For those of us that it was new. And so it's a really big learning curve. And when I went to the literature, I kept seeing Rose, Wouters, Rose, Wouters. And I thought, man, I would love to meet those people someday. And to their credit, I emailed them out of the blue, and I'm sure they get that all the time. And these two individuals don't know me. They have thriving, busy careers, and they took the time to email me back as a young mom with a child who was just diagnosed and feeling absolutely overwhelmed. And it meant the world to me at that time because I didn't have a touchstone. Our own specialist didn't understand Blau. And it is to my absolute joy that years later, I get to speak with these two individuals on a regular basis. And I can tell you, as proud of as we are of them professionally and thankful for their work, they are kind, amazing people who have a heart, not just professionally for Blau, but they truly care about this community. And so it's such an honor that they're here today. And I want to share a little bit more about who they are so that as we enter into this forum today, you can really orient to their work that they've done in the Blau syndrome community. And both of them are newly retired, so that's going to be a part of their bios, but I kind of chuckle when I say retired because that's absolutely not accurate. Scheduling a meeting with them is near impossible because they're in this country one day, at this conference one day, and they are just still completely active in this world and within their scientific community. So retired is in quotations. It's not accurate at all. In fact, I worry a little bit about you guys. You gotta take some vacations here now and then. But actually, selfishly, I am glad they are still so committed to our community. So Karen Wouters is a retired pediatric rheumatologist, and she's worked at Leuven University Hospital in Leuven, Belgium. She was head of the clinical department of pediatric rheumatology and immune inflammatory diseases at the Leuven University Children's Hospital. And she's also a professor in pediatrics at Leuven University. She is the executive board member for pediatric rheumatology in the European Reference Network for Rare Immune Deficiency, Autoimmune and Autoinflammatory Diseases. Dr. Wouters is a medical advisory board member for the Cure Blau Syndrome Foundation, and many of our patients are familiar with her work. Her major research activity focuses on systemic juvenile idiopathic arthritis and macrophage activation syndrome, autoinflammatory diseases, and granulomatous inflammatory diseases in children with a special interest in Blau syndrome. She works very collaboratively with Dr. Rose, who is here today as well. Dr. Rose is a retired pediatric rheumatologist and a master of the American College of Rheumatology. He practiced in Wilmington, Delaware at Nemours Children's Hospital as a professor of pediatrics at Thomas Jefferson University. Dr. Rose practiced medicine for over 46 years with peer-reviewed research examining Blau syndrome, juvenile idiopathic arthritis, and Lyme arthritis. Dr. Rose is also a medical advisory board member for the Cure Blau Syndrome Foundation, and he's personally consulted with many patients with Blau syndrome during his tenure as a rheumatologist and beyond. Dr. Rose and Wouters, I'm going to turn this over to you now. And as I can say, we are so excited to learn from you today. So thank you so much for your contributions, and the floor is yours.
Okay, well, thank you so much for this wonderful introduction. It is really, some of this is clearly undeserved, but I really appreciate it. And I am really honored to be part of this experience online. So first of all, good morning, afternoon, and evening to everyone. So this is my first slide. I hope it's easy to be seen. Okay, Erica? Correct. So Blau syndrome is a monogenic granulomatous disease. Monogenic meaning that is the result of an alteration of one gene. Dr. Wouters will explain that better. And I usually use this slide to portray the fact that Blau syndrome is rare, but it helps us understand the rest, a lot of the rest of the diseases, including those who also have granulomas in their inflammation and also arthritis in general and uveitis. So the agenda today will involve three major areas. I will be focusing on the clinical triad, which is the main set of clinical elements in the diagnosis, and also some of the natural disease course of these particular three manifestations. I thought that I had to honor the granulomatous disease by introducing you to what a granuloma looks like in the microscope. On the left side of the screen, you see the classical granuloma, the granuloma of tuberculosis. And you can, for those who are not medically aware, each one of these black dots is a nucleus of a cell. And you can see that this granuloma, you hope you see my pointer, has a big round or round-like structure with a rim of cells in the periphery. And in the center, there is nothing. And that is what characterizes a tuberculous granuloma, where this tissue inside is destroyed. And that is what is called caseating granuloma. On the right side, you have the opposite, pretty much visible, also a round structure with a corona around, but also full of living and dividing cells inside. And that is a non-caseating granuloma, and that is what Blau syndrome represents. A little bit of history. 1985 was an important year for this condition. In November, Dr. Edward Blau, who I had the chance to meet, is a wonderful man, presented or published a 4-generation pedigree of 40 individuals, with 11 of them affected by the disease, which was characterized by inflammation of the joints, that's called synovitis, with more of that later. Tenosynovitis, which is inflammation of the tendon sheath, 3 uveitis, and 3 head rash, which we will talk about. It's interesting. Have I seen this, I wouldn't have done what he did, but it so happens that Ed Blau is a nephrologist who was covering for the rheumatologist that season. And so he went ahead and thought it was too strange to have a family without people with arthritis, and to obtain the biopsy of the synovial membrane of the joint, and found these typical non-caseating granulomas, and that is why he knew that this was something different. He also described the granulomatous uveitis in his paper, and 2 skin biopsies with granulomas in the skin rash. He showed these abnormalities to be absent, which are typical of other granulomatous disease, and published this in the Journal of Pediatrics. However, he did not recognize that a few months earlier, Dr. Jobs, as this was May, published pretty much the same thing with some differences that are not that relevant, but he published this in a journal for adults. It was the American Journal of Medicine, and that's probably why Dr. Douglas did not read Dr. Douglas' paper. But in the West Coast, where Dr. Douglas Jobs practiced, many people still call this Blau Jobs syndrome in recognition for this colleague that actually preceded it, but did not do such a great job describing the disease as Dr. Blau, and that is why we call this disease Blau syndrome. So what is that triad? What are these three manifestations that characterize that they are the backbone of the clinical presentation? First is a skin rash. So you can see here is a very fine, what we call papules, that little bumps, tiny bumps. You have the umbilicus to compare to see how small these bumps are and why is it so many times missed when it happens. And then you have the other elements, the synovitis, which is the inflammation of the joints, and you can see this prominent bulging wrist joint, as well as involvement of some of the knuckles. And then you have the hallmark of this uveitis, which is how the eye looks when you look through this using a regular examination with light. We'll do more of that later. This is a patient with uveitis. One of the characteristics is that the inflammation changes the color of your iris, and that's why this looks like a different color on the right versus the left eye. This is one of the first families that I met. These are three members, mother, older son, and younger son. This mom would have a third child who also had the disease. And so this was a 4-member family eventually. This was published in 1996 by my group, and that was because we found for the first time involvement of the liver. You can see some of the characteristics, which is this bending at the knuckles of these intermediate joints of the fingers, and that is called camptodactyly. You can see some of the discoloration still on the rash, but more of that later. And Dr. Wouters will talk about the liver involvement in this disease later on. So the articular features of the arthritis associated with Blau syndrome are camptodactyly, which is this bending at the, this is called the PIP joint, which is the intermediate joint of the finger. You can see here the scar of the synovial biopsy that was performed on this patient. And you can see this thickened entire digit, the entire finger that's not just at the joint, but between the joints. And that is because the tendon sheaths are involved, and that creates this fat finger. And in this case, it's called the extensor digitorum tendon. You see the wrist synovitis, which you saw much better in the other slide. And the right, I just wanted to give you some idea of the anatomy. This is a very, very simplified graph, but it shows the two bones forming the joint. It's called the diarthroidal joint. This is a muscle happening there and a capsule that surrounds the entire joint. These in blue are the shiny cartilage that is in the joint at the end of the bone. You've seen them when you prepare chicken. You can see that what that cartilage is. And this green structure, that is lining the space in the joint is the synovial membrane, and that is the tissue where the Blau syndrome arthritis, and actually most inflammatory arthritis, that's where things begin, the synovium. These synovial cells produce fluid, and that fluid fills this brown space and enlarges the joint. Just to have an idea how this looks in the microscope, on the left side, you see this is a photograph of a microscopy of a synovium, a piece of synovium by biopsy. The gray space is the space, actually, the space where the synovium gives to, or you can see. And you can see that it's normal, you can see 2 or 3 layers of synovial cells. That's the normal synovium. Here, in a case of rheumatoid arthritis, you see the enormous proliferation. You can see probably 15 or 20 layers of cells lined up in the joint. That creates more cells that produce more fluid because each one will produce more fluid, and also how the membrane gets thickened. Here you have an example of Blau arthritis. That's a synovial biopsy of a Blau patient. Here at the top, you can see this, the same as you see in rheumatoid, many layers of inflammation. But here you see what is the hallmark that differentiates Blau from rheumatoid or juvenile arthritis or any of the other inflammatory arthritis. And this is the presence of this granuloma with this giant multinucleated cell here. You can see this cell here with multiple nuclei, probably 15 or 20, when, of course, as you know, there should be only one. So this is how the synovium looks like in rheumatoid arthritis, in Blau arthritis. More on the characteristics. Again, you see one of the brothers here with the wrist is a characteristically, we call it boggy synovitis or cyst-like because it's really, really large and puffy. And when you feel it, it feels like a little water balloon. That's the sense you get when you palpate this. You can see the same thing here in the thumb joint. Now, one thing that is characteristic of this disease, unlike rheumatoid arthritis, juvenile rheumatoid arthritis, is that you can still get a pretty decent range of motion when you range the joint, like in this case. You would not be able to do that in a patient with juvenile arthritis who has so much synovial inflammation. So it's inflammation which doesn't really affect as quickly and as severely the architecture of the joint space as it does in other inflammatory articular diseases. And this is more proof of that. You can see in x-rays of the hands. Of course, I understand that you're not familiar with x-rays of the hands, perhaps, but this is a child that was 13 years of age when it presented and had the onset at age 2. So this is 11 years of unrelenting inflammation of the joint, and you still see a pretty well preserved joint in terms of what you see in the x-ray, with the space between the little carpal bones preserved and no much erosive disease in the space that you normally would see here and here. You will see little holes in a patient with rheumatoid arthritis. This is another age 20. This thing is one of the brothers. Yes, the carpus is a little shortened. Yes, you can see some deformities on the bone, but you still see the spaces quite preserved despite the length, the number of years of inflammation. This is the mother of these two children. You can see this kind of flaring of the bone, this contracture due to the camptodactyly, but you still see very little in terms of erosion. I should have presented you with an x-ray of a rheumatoid hand. You can see the difference, but I didn't think of doing that. This is the mother. This is the lady of this, corresponds to these hands. You can see the contracture, the bending of the fourth and fifth. You can see it here on the x-ray. The other aspect is the inflammation of the tendon sheath. This is the extensor tendons of the wrist. You can see that it goes this way and continues towards the hand because the tendon sheaths are made out of the same thing as the synovial joints. And that's not surprising that it's affected. You can see this in this ankle, the presence of inflammation of the joint, but also a little hose here, which represents the peroneal tendon. And you can see how and this is not the joint, this is the tendon sheath. You can see it in several tendons in this case. What about the rash? We call it a tan because it's brownish and a dirty appearance. When you look at it, this is a long-standing rash, not that popular, that bumpy as it was, but it looks more like a tiger-like dirty appearance of the rash over the years. And I've seen this disappear, and I've seen this persisting even in adults. It's not itching, it's not painful, is just there. This patient I saw when I was a trainee, and then saw in my clinic 20 years later as an adolescent. And this, you can see how the rash looked like in the baby. He was trying here to get the bottle. That's what he was doing with his hand here. Got the bottle and started sucking up him. Beautiful baby, did very well for many years. And this is what you see when you biopsy the skin. You see this is the epidermis, this is the dermis, and you can see granulomas that are similar to the granulomas that we see in the joint membrane. This is how it can look like, and this is a baby from Dr. Bourrat in Paris. A baby is a patient of Dr. Bourrat. You can see around these little papules in the face, in the arm. It looks like quite unremarkable. And this is just the more on the, this was in the same slide, but already show you the camptodactyly as you progress with the disease. The uveitis is seen in 3/4 of patients with Blau. I have to say that usually appears a little later with 2 years of delay from the joint approximately. Age 4 is the age of the uveitis. It's in both eyes most of the time. And different from the uveitis that we see in juvenile arthritis, this uveitis, which is seen in both chambers of the eye. I didn't have a graph here of the eye, but the uveal tract is it comes from the Greek term from grape, because it looks like a grape. It's the membrane that is inside the eye, and it is in charge of cleaning inflammation and also nourishing some of the tissues in the eye that, for a reason that we need transparency in those tissues, they don't have blood vessels. So they get nourished through the uveal tract. And this uveal tract goes all around the eye or inside the eye. And everything that happens from the lens to the front is called anterior, and all that happens from the lens to the back is called posterior, with some other section called intermediate uveitis. This may be a little complicated to understand, but we're happy to take questions. And this is how an eye involvement of the back of the eye or posterior uveitis looks like, with this little nodular little nodes and little excrescences, which are representing scars. This was given to us by Dr. Gooley, who is a collaborator of ours in England. And this is the study we performed. Was the largest study ever done on the eye disease and Blau syndrome. Was a natural history study where we follow up a patient for a long period of time. And you can see on the a bunch of funky words which represent the percentage of patients who have a given manifestation. Many of them some of you already heard of. And the color code shows which part of this donut, what percentage of patients suffer the disease. We did this study on 75 eyes, which is kind of a funny way of counting, but that's how the ophthalmologists like it. And these are the complications that you see: band keratopathy, optic disc changes, posterior synechia, which is extremely common, and it's just scarring tissue that doesn't let the pupil work. Chorioretinal changes, I show you some picture, cataracts from the inflammation into vicinity of the lens that gives you cataracts, increased pressure, and which is not exactly the same as glaucoma, and retinal detachment. And this is the outcome. The good news is that 60% after a pretty long period of observation have never developed vision loss. They need correction, but not visual loss. And then 15% actually lose vision completely, and in between, about 30% have a moderate visual impairment. The logMAR is a way of measuring the visual acuity. So this is pretty much the outcome of the natural history of the uveitis. I think that the two set numbers to remember: you expect it to happen around age 4, you expect it to happen in 3/4 of the patients, you expect it to happen in both eyes, affecting the anterior and the posterior where the optic nerve leads, which is this guy. And then what you expect to see is that the overwhelming majority, 60%, will preserve visual acuity, with the rest having some degree of visual loss. I think this is it for me. This is the next step of the agenda, and my colleague and dear friend for many, many years, Karen Wouters, will take it from here. Thank you very much, and you are ready to share your screen now.
Thank you so much, Dr. José Carlos, for this wonderful first part of our presentation, which I can tell to the audience, which we conceived together. I'm now looking for the second part, and I think you can see my screen?
I can.
You can?
Mm-hmm.
And so it's my pleasure now to everyone also to welcome you. Good morning, afternoon, and evening for the European friends. And so I will say a few words on other manifestations then beyond the clinical triad, which were mentioned by Dr. José, and say a few words on what we know of the genetic cause and the mechanism of disease. As a start, I thought I would share with you that in 2005, Dr. José and I have set up an international registry with the aim to collect data on the clinical features, on the genetic profiles, and on the treatments received by Blau patients. But we also wanted to know more about the disease course and the outcome of the triad and beyond. And we wanted to have a better understanding of the genetics, of the mechanisms of disease, and hoped to find biomarkers that could indicate disease activity. And so therefore, as you can see here, we contacted a number of colleagues in multiple centers in different continents and asked them to become involved together with us in a prospective cohort study in which we included a number of Blau patients who all had the mutations, who were followed in a systematic way, who were evaluated, and who also provided a sample for research purposes. And as we already knew from several observations in the past, Blau is a systemic disease, and it can affect a wide variety of organs beyond the clinical trial. And actually, this was confirmed by the data from our registry, as you can see here on the pie chart. We put together data from 82 patients with Blau syndrome. And as shown here, there was a large variety of clinical features, clinical manifestations, extending beyond the classical triad mentioned by Dr. José: skin, eye, and joint disease. Let me just give you a few examples. So in addition to the classical rash with the tiny bumps that you saw, patients may also show this kind of local swelling with redness and pain that could suggest a skin infection. Or they could have these nodular, larger, bumpy, reddish lesions that we call erythema nodosum. Here on the left, this was a child who presented with an enlarged liver, and when a biopsy of the liver was performed, a granulomatous inflammation was documented. In another child, in the middle, who presented with some abnormalities in the urine exam, it was found that the granulomatous inflammation had also affected the kidney. And at last, these images show how inflammation can also affect the blood vessels, the large blood vessels. And this was seen in an Indian child who was known with Blau syndrome, who had Blau arthritis and who had a mutation, but at a certain age presented with general unwellness and high blood pressure. With the prospective cohort study, where we could follow the patients in a more systematic way and over a couple of years, it has become clear that the expanded, the extra-triad manifestations could happen in almost half of the patients. And this is shown on the graph here. And as you can see, fever, prolonged fever is not that rare. It was seen in almost 25% of patients. It can be the first sign of the condition, and it may recur, especially during the first years of the disease. Patients may also have enlargement, involvement of the liver, the spleen, or the lymph nodes. Patients may have hypertension even at a young age, and they may have kidney involvement, which needs to be monitored for. Very few of patients, as you can see, less than 10%, in less than 10%, Blau did also affect the lungs or the central nervous system or the cranial nerves and the blood vessels. And the erythema nodosum, as I showed, was again a frequent manifestation. So as a consequence, monitoring during the follow-up of patients with Blau syndrome is very important. And as we speak, I'm glad to say that new guidelines for monitoring are being drafted, being finalized, together with the help of a group of Blau colleagues, and also with the input, thanks to the input of Troy Townsend of the Blau Foundation. And so we can say that it is essential to perform a clinical examination of the joints and of the eyes with a complete eye exam. But in addition, it's important to do a general examination, including taking the blood pressure and palpating the peripheral pulses. A few laboratory tests may be useful, although not many lab tests are needed to follow a patient with Blau syndrome. The blood cell counts, as you already know, are most often normal, although some patients may have anemia, a decrease of the red blood cells, or a decrease of the white cell counts. And also, typical for Blau, the classical markers of inflammation, the sedimentation rate, CRP, or the angiotensin-converting enzyme are most often normal. Autoantibodies that we find in classical forms of juvenile arthritis are absent. On the other hand, it is very important to monitor the function of the liver, of the kidney, to perform urine analysis, and also monitor the levels of calcium in serum and in the urine, and of vitamin D3, because calcium levels may be elevated in Blau patients, which can cause kidney stones. And upon any indication, such as a prolonged fatigue or a persistent cough, one should consider additional investigations, including a chest X-ray or an echocardiogram. Let me say a few more words about what we know about the genetic cause and the mechanism of disease. Blau is truly called an autoinflammatory disease, or in other words, a disorder of the innate immune response. And this cartoon represents the major players of the innate immune response. These are cells, monocytes, neutrophils, and macrophages. And these cells can pick up signals of pathogens or of danger, called PAMs and DAMs. And they can pick up these signals thanks to receptors on the cell membrane, TLRs, or inside the cell, NLRs. Not 2 is an NLR. Upon picking up these signals, the cells will activate inflammatory pathways that will lead to the production of little molecules that we call cytokines and chemokines, which will recruit more innate immune cells. And this then will lead to the development of inflammation and risk of organ damage. We know now that Blau syndrome is a member of a growing family of autoinflammatory diseases, as shown here, which are all caused by genetic variants of the innate immune system. Here you see Blau, and here you see many other members of this growing family. And at present, more than 50 genetic causes have been identified. It was Edward Blau himself, Dr. Edward Blau himself, who, as already mentioned by Carlos, who proposed that this condition was caused by a genetic alteration, because in his original description, and I'm showing you the original pedigree with the 11 affected family members over 4 generations, he clearly demonstrated the familial occurrence and an autosomal dominant inheritance pattern, which means that every 1 in 2 children of an affected parent has the risk of having the disease. He found the granulomas, as already mentioned by Dr. Rosé, in biopsies of the joints or of the skin. So a genetic cause was proposed by Dr. Blau, but it took some more years. Actually, it was in 2001 that it was possible to identify this genetic cause. And this was done by Dr. Corinne Missely-Richard in 4 French pedigrees, where she could demonstrate that the affected patients, affected family members, all had mutations in the NOT2 gene. The NOT2 gene is a gene that is responsible for the production of the NOT2 protein. And this protein is depicted here, stretched out. And as you can see, it is composed of different parts that we call domains, and that here are colored in different colors. I'm putting here a graph that is depicting the Blau mutations that we found in our registry. And so you can see that the majority of Blau mutations are located in this part of the protein, NACHT, NBD, or close to this part of the protein. And that you can also see that the vast majority of patients had a mutation at a particular position of the protein, which is position 334, which is a kind of hotspot for mutations. These are the most frequent forms. And these mutations are associated with a complete triad, but they can also be associated with an incomplete triad, or they can be associated with an expanded involvement. And even it can happen that a person carries a mutation without having disease, without having Blau disease for some variants. And this we call asymptomatic variants. And at last, and this has been demonstrated by the geneticist of our consortium, Dr. Juan Arostegui from Barcelona, there exists such a thing as somatic mosaicism, which means that the mutation is only present in a small proportion of innate immune cells, not in all cells. And this means that it can be difficult to detect by routine genetic testing, and that it requires specialist genetic testing methods. Just as an example, so we found incomplete penetrance of the NOT2 mutation, which means that the mutation is present in the person, but it doesn't show up. And we found this in a Blau syndrome family who had 2 affected members, indicated with the black circles, and who had 4 other persons, indicated in the gray, who had the mutation, but without any symptom or sign. And as an example of an incomplete form of Blau syndrome, I'm showing you this family who was described by Dr. Tammy Martin, and she found a particular mutation, E600A, in 7 family members of this large family who had an isolated granulomatous panuveitis, which had started in childhood or early adulthood, but without any other sign or symptom. So no arthritis, no dermatitis, just eye involvement. Let me then go to the NOT2 signaling pathway. How does this mutation in NOT2 cause inflammation? Well, as mentioned, NOT2 is found inside innate immune proteins. And upon certain triggers, such as microbial patterns or microbial particles, NOT2 becomes activated, and it will form complexes. And these complexes will set in motion a whole cascade of protein just into the nucleus. And so in the nucleus, it will activate, genes will become activated, and this leads to the production of inflammatory cytokines and chemokines. Now, this is in normal circumstances. However, in Blau, the NOT2 mutations will cause an abnormal behavior of the NOT2 protein, because the NOT2 protein will spontaneously and persistently activate this signaling pathway, and this will cause an exaggerated and an uncontrolled and persistent release of inflammatory cytokines and chemokines. So the relation between the NOT2 mutation, the NOT2 protein, the NOT2 mutation and inflammation actually is quite clear from what we know. The relation between the NOT2 protein and mutation and the granuloma formation is still much less understood. But we do know, as already mentioned by Dr. Rosé, that granulomas are a key feature, a cardinal sign of Blau syndrome. And as you know, these granulomas are kind of clusters of immune cells that stick together. As you can see here on the right, they stick together in an organized fashion. And in Blau, they are abundant and they form groups or complexes, as you can see here, that can occur in a variety of tissues and organs. When zooming into a granuloma, you can better appreciate the structure. But this was mentioned, the central core with the macrophages and the giant cells with a ring of nuclei, and an outer corona with lymphocytes and fibroblasts. These granuloma cells are not just sticking there together, they are activated. And indeed, we performed in one of our studies staining for inflammatory cytokines on biopsies of Blau patients. And we could see that there was an abundant and widespread production of granulomas inside the tissue, which corresponds to what we see in the clinic, the inflammation of the skin, the joints, the eyes, and maybe other organs. So this is where I wish to end. I think much more is to be shared, much more is to be done, much more is to be asked, but we hope there will be another session where we can return to other aspects. And in the meantime, I want to say just a few words of thanks. First of all, to Dr. Carlos Rosé, who initiated this Blau project more than or almost 20 years ago, around 20 years ago, and who continues to be relentlessly engaged in all its aspects. I wish to say a word of thanks to the many doctors and scientists who joined our network and our research activity, to the many patients who were willing to share their data and samples, and especially to the members of the Cure Blau Foundation, Troy, Cherilyn, and Erika, for being inspirational to what we do and supporting our efforts to try to better understand the disease and hopefully one day help to find a cure. Thank you. I will be happy to take questions as well.
Thank you so much. As Dr. Wouters had referenced, you'll see below there's a little chat box on your screen. If you have questions, that's a great spot for you to enter them in, and then I can read them as they come through and I'll present them to both Dr. Rosé and Dr. Wouters. This is your chance to ask away. These are like, if there's someone to ask about Blau, it's the two of them. And I know I had so many questions. I still do constantly. And one of the things that was really notable about your presentation today is that you really validated the piece of expanded manifestations. I know for a lot of our family members, I think that specialists or doctors who treat them only are aware of that classic triad of the eyes, the joints, and the skin, right? But a lot of our patients report having these additional symptoms that oftentimes are not examined by their providers or are not really validated. And so I think that it was really nice to see you guys present a really clear portrait of how Blau has this additional impact on patients. And we definitely see this through the foundation. In addition, I think it was also wonderful that you were able to address the fact of the classic inflammatory markers are often normal in Blau, because again, this is a really big problem for our patient community. They experience this symptomatology and this discomfort, but oftentimes because their blood work is normal, it's not taken with the gravity that it should be. And so I just think the information you provided is so relevant for our practitioners and our specialists to read. And I know for me, it was very validating and for a lot of our patients. One of the questions that has come in from Zoe, and it has asked, and if you are also welcome, everyone to click on your chat box and read. It's a great question. What if your child has a PST-PIP1 mutation for Papa syndrome and NOD2? Could these two autoinflammatory diseases moderate each other and influence the innate immune system?
So we started with the easy questions.
Right. Jump right into it.
Do you want to take it there, Karen, about what specifics on the NOD2 variant that this patient has, which is crucial?
I'm not sure that I saw the question. I see a question about the discovery. I'm sorry, could you maybe recall?
Above it, and I apologize if I'm going to pronounce this wrong. I'm not familiar with it, but if this is too in depth, we can actually even circle back later after the forum. But it's a great question that surrounds, and it's something I'm not familiar with. But it's PST-PIP1.
Yeah, it's Papa syndrome.
Yeah.
Mutation for Papa syndrome and NOD2. So could these two autoinflammatory diseases moderate each other and influence the innate immune system?
And that's why I asked the question is, what exactly is the NOD2 abnormality? Because NOD2 is a polymorphic gene, and there is a lot of variants in NOD2 that are not pathogenic, so that do not produce pathology. So it's crucial to me. The first question is, what exactly is the substitution in NOD2 in this case? Do you agree with that?
I would fully agree. And I also think it's important, what are the symptoms that the child presents? Are these compatible? Are these in line with what we know that NOD2 can cause or not? On the other hand, I think it's a very interesting question. And as we are discovering more and more about the autoinflammatory disease spectrum, we are also realizing that the genetics is more complex than we initially thought. It's not just one gene gives one disease. And it has become clear indeed, as suggested by this person, that several genetic polymorphisms rather than mutations, and just variants that are not so pathogenic, but that they can influence each other's impact. So it's interesting, but for answering for that particular patient, it would be good to know the mutation and the clinical signs.
Thank you. Regarding female patients that have Blau, is there any information regarding disease progression, suppression, around age of menstruation and or pregnancy? Do hormones play a factor in disease progression?
Well, let me take one part of the question. This is an autosomic dominant mutation, meaning that the genders are equally distributed, and the classic teaching is that during the pediatric age, we have seen no major differences in terms of type of disease and outcome, at least in the pediatric group that we have identified. Karen?
No, I fully agree. Now, about disease progression, the relation between hormones and disease manifestations, I would not be able to answer. I didn't follow any adults, even not young adults with the disease. I don't know, Carlos, you have...
Well, I can say that fertility doesn't seem to be affected. This is a familial disease with 3-4 generations of affected individuals. I have this family with mom actually having 4 children, 1 without disease and without mutation, and 3 with the disease, and no complications in pregnancy. And importantly, or perhaps importantly, different from rheumatoid arthritis, this condition does not affect the hips and the pelvis so much. So I haven't heard of difficulties in terms of delivery, labor, particularly, and delivery. I do know, we all know that some of the drugs that we use in patients with Blau syndrome are clearly not easily tolerated by the fetus. All of them can be damaging to the evolving fetus. So that's important to understand, but that's related to the treatment more than the disease. And as all autosomic dominant diseases, the risk of inheritance is around the 50%.
Okay. So it sounds like a lot of the information is around pediatric patients at this point, but from what you've seen, you're not seeing much of a significant difference. But it would be interesting to investigate the role of hormones and the role of the disease during pregnancy. Someone had commented that during their pregnancy, they had severe high blood pressure and preeclampsia. Wow. So
True.
Right.
Yep. We have one woman who had developed a pulmonary thromboembolism during pregnancy with Blau syndrome. So it is obviously there's some details on the outcomes that I was trying to answer in general. But there are going to be circumstances where exactly when you have hormonal changes, you have more tendency to form clots and other things. That would be too much of fine tuning to answer that question completely. But yeah.
Yeah, absolutely. This is a question that I think a lot of us who had our babies with Blau have wondered, but there's an individual in Ireland who has a 2-year-old that's diagnosed with Blau just a year ago. And I think the thing that's tricky as parents is when they're so young, they can't verbalize the pain level and the discomfort they're feeling. So have you noticed a pattern of how children will present, young children with pain, and how do we balance medication to support the pain level they're feeling when they can't verbalize it? Have you had experience with that in your practice, and how do you approach that?
Should I take that, or you want to take that?
I do think that you have seen more young children with Blau than I did. I rather compared to other diseases with arthritis. I mean, juvenile arthritis. If it's about joint pain, the question, and I think that probably it's not that much of a difference between Blau arthritis and juvenile arthritis, although patients with Blau arthritis, for the fact that the joint is less limited in movement, may even be less painful compared to juvenile arthritis patients. But evaluation of pain in a young child with arthritis is indeed not so easy. It's, I think, changement in behavior, not using the articulation as before, trying to avoid certain movements, certain activities are all warning signs for the mother to share with the physician. And then it's a very good clinical exam, I think, is essential to discover. I don't know, Carlos, if you have.
Yeah, one of the problems that I had with answering questions related to pain is that pain is an individual experience. And when I mean individual, I include the pair of child and parent. And we in rheumatology use the paradigm of juvenile rheumatoid arthritis as our standard, and of course that's a standard with a lot of pain, because these are, for us, everything is compared to the most common rheumatic disorder of childhood, which is JIA, juvenile arthritis. And in my experience has been that children who have ankle and knee involvement, first of all, they don't get hip involvement, which is a big plus for the Blau patients, but also the fact that the range of motion is preserved, they limp less, they have less limb growth abnormalities in my experience. But of course, the pain experience is there, and I as I said, I compare them with the rheumatoids, but that may be an unfair comparison because that is a very painful disease. And so again, we in the saying in pediatric rheumatology is children do not express the word pain, they behave the pain. They express it by the way they walk, the way they want to do things, or they stop using the limb. And we in rheumatology learn how to interpret those symptoms.
Mhm. And related to that, have you found that, do you have any guidance? As parents, we sometimes can't differentiate what's a side effect from a drug and then what's a direct outcome from the disease. And I think a lot of times our doctors don't know that as well. Do you have any recommendations to how we can better differentiate?
What drug do you have in mind that can be confused?
So let's say like with methotrexate causing like intense stomach issues or nausea. I know that's not typically a disease characteristic, or just general discomfort sometimes. So let's say if you're a young child with methotrexate and they're uncomfortable, but it's related to the side effect of the drug versus disease manifestation. And so, or let's say Humira as the specific drug. So,
okay, sure. Well, as prescribers of methotrexate for since the 80s, we learned to love and hate that drug. And I do say, first of all, it's important to understand that if any organ is spared in Blau, that's the gut. The GI tract is usually not affected by Blau syndrome. That's not to say that the other abdominal organs cannot be affected, the liver, the spleen, but actually the gut itself is usually spared from the Blau granuloma. But methotrexate can produce decreased appetite, malaise, tiredness, and of course, significant nausea and vomiting. So if you have to choose in a methotrexate child with Blau or any other disease, and they present with this nausea, vomiting type of symptom, is the drug. And the answer is a drug most of the time when it comes to those symptoms.
Right.
You follow me?
Yes.
Yes, and I would, pardon, I fully agree. And I would also add that also in general discomfort, vague discomfort may just be methotrexate.
Yeah.
Of course, one has to examine the child in its totality and maybe do a blood cell count and a liver test and see that everything is normal. But general discomfort a whole week long can be due to methotrexate taken on a single day. It's really
unwellness, huh? Is a word unwellness.
Yeah, absolutely.
Yeah, and it's an interesting, it's definitely interesting as parents. We know things like, when they're recovering from Remicade infusions, or like someone referenced Humira, if you have kind of general fatigue or just an overall feeling of, I know some of our kids kind of a feeling of malaise. It's kind of an overall feeling of not feeling well. It's just interesting a lot of times to parcel out what is what when it's not it doesn't sound like such a direct typical characteristic of Blau. So I think sometimes that's a hard thing as parents to kind of parcel out. There's also a question related to nephritis, and it was if there's a known correlation between IgA nephritis and Blau.
I don't know of any, but you no.
Me neither. I'm not aware. It's interesting because Blau was a nephrologist, and so he would be interested.
It's confusable. They may be similar clinically. They could have this. Rarely Blau can present with this vasculitis that looks like little purpura in the skin and kidney disease. So they can be confused at that level, but as far as I know, IgA has no specific function or effect on Blau syndrome.
Is there any evidence when we look at specific mutations in Blau that there might be a particular drug or therapy that works more effectively with that mutation? So,
we're not there yet. We're not there yet. We don't have a drug that is effective to start with, much less for the different subsets. I'm sorry for being blunt about it, but
indeed, and on the same level, we don't have good correlation between a specific mutation and the phenotype and the clinical manifestations. We can't say that if you have that mutation, you have a high risk for expanded manifestations or severe uveitis. At that level, there is still a lot to be uncovered.
That was one of my big questions, what you just addressed, is if we can predict disease symptomatology based on genetic mutation. And it sounds like
there is absolutely nothing. There was some work by the Japanese group that seemed to suggest that one type of mutation had more eye disease. That wasn't confirmed. So I think that at this point, the mantra is, except when they have these non-genomic mutations, like the patients that were described by Arostegui, where they have mosaicism, meaning not all the cells being mutated, and those have a milder phenotype, and those are the ones that are probably diagnosed as adults. Non-genomic, non-germline mutation.
right.
How do the Arostegui calls them the
Somatic mosaicism.
somatic mosaicism. Somatic mosaicism. Yeah.
Awesome. We have a couple more minutes. There's a couple of questions that came in that are specific. One is there a correlation between Blau syndrome and Barrett esophagus? If you're familiar.
Don't think so. That would be a news to me.
Yeah, for me too.
Yeah.
I'm not aware.
Is there experience with using, I'm going to pronounce this wrong, mycophenolate mofetil?
Mycophenolate mofetil. Yes.
There you go.
Yeah.
Together with
That's Cellcept. That's Cellcept.
Cellcept, great. That's easier for me to pronounce. Together with Myra and Ilaris for treating Blau, especially in regards to keep eye inflammation under control.
You want to take that, Karen?
Well, experience is a big word, because it looks like this is a cocktail that is being proposed for a very difficult to treat uveitis patient. But what we can say is that Cellcept is being used in rheumatic conditions in general, so it surely can be proposed in a similar way as methotrexate is being proposed, and especially if there is no good response to methotrexate or intolerance to methotrexate, Cellcept could be a good option. And then the combination, I understand there is a combination being proposed of
two biologics and Cellcept. Yeah, I've used Cellcept with Humira myself, with Remicade actually, together. Haven't used two biologics together, but I heard of many that have, correct?
Yeah, I think it's not standard using two biologics, and one has to be aware that also risk of infections might increase the more immunomodulating drugs that you add. So one has to be very careful. But of course, in very difficult circumstances, it might be an option. They target different cytokines, and we know that anti-TNF is not that effective always for the eye disease. And there are some cases, as were shown by our Italian colleagues, that did respond to anti-IL-1 treatment. So it could be.
That's hilarious for those who don't know. I see, to treat eye disease, almost all bets are out, and everything is sometimes necessary, very experimental circumstances to save the eye.
All right, two more questions for you. I'm going to read this one word for word. Thank you for this great event. A question for Dr. Wouters. You mentioned that the registry is also aimed at identifying biomarkers. I have in mind a patient who presents some signs of Blau syndrome, no biopsy done yet, and who carries a variation of uncertain significance, ACMG class 3 of the NOD2 gene. A biomarker could be useful to support or refute the diagnosis.
Yeah, unfortunately, our search for a diagnostic biomarker has not yet come to a proposal. So as of today, we can't say that with this blood test and that biomarker, you can confirm or exclude that a patient has Blau disease. I think at present, what is important is looking at the clinical manifestations, if these are compatible with what we know about Blau, and if possible, do a biopsy to see whether our granulomas present in an affected tissue or an affected organ. and then exclusion of other conditions if you have a variant of unknown significance. But unfortunately, there is no biomarker yet available that can replace these other components.
A warning about genetic testing. Genetic testing has become extremely available, and a lot of patients get genetic testing. Interpreting those genetic results is the art, is the difficulty. And we find ourselves many times having to consult with our colleague, Dr. Arostegui. So they run it through different softwares to see if that variant observed in the DNA testing is likely to be significant or pathogenic. It is not that easy to say yea or nay just by looking at the substitution itself. You have to look at a lot of things before you say this is significant or maybe significant or not. And we do that all the time. Thanks to Dr. Arostegui, he gets a lot of emails with, what do you think about this variant? And he would answer in a week or two.
We've been hearing a little bit more lately from patients about central nervous system dysfunction. Can you speak on what that looks like a little bit more?
I let you answer this one, Karen. You're the extra triad person.
Central nervous system. Well, I mentioned it, and we have seen it. We know that there can be inflammation at the level of the central nervous system. Although we have to stress that this is very, very, very rare. It's only a very small percentage of Blau patients that we encounter this phenomenon. So if you say central nervous system dysfunction, one should also question whether this is due maybe even to general inflammation. If the disease is in general active, that the child becomes tired, loses concentration, is irritable. This could also be a consequence of inflammation outside the central nervous system. Another aspect is the drugs again, like for instance, methotrexate can cause also malaise in general, then could be interpreted as dysfunction of the central nervous system. So I think it's very important to very clearly explain what is meant by central nervous system before attributing it to real granulomas inside the brain, because the latter is extremely rare. It's not excluded, but it's extremely rare.
Right. Okay. And then our final question, is it possible from an epigenetic perspective that NOD2 gene mutations become irrelevant at some point in life if they were prevalent before?
Epigenetics, that's the question that I wasn't expecting. Okay, so let me answer, take this, I'm sure Karen will say more. Their genes, when are there, can be affected by multiple things later on. One of them is epigenetics, which is mainly acetylation and other changes that occur in the chain of DNA and the histones that wrap them around. We know that that must be happening. Maybe another thing called, sometimes it's not epigenetics, but another gene that is abnormal that balances the effects of the NOD2 gene. That is similar to epigenetics, but it's not the same thing. And we know that it happens, at least in those who have genetic mutation and never had the disease. And that's a good example. Something is modulating the expression of that gene. So something may happen that having the mutation doesn't mean you will have the disease, although likely will. But again, influences on those genes are, one could be epigenetics and one could be a second gene affecting the first.
Okay.
Did I answer the question?
I think so. I think, is it possible if that gene is expressing itself at a young age, let's say at age 45, could the gene somehow express itself?
Turn off of that, I don't know. Karen, do you know anything about that?
No.
I don't think so. But
everything you said about the epigenetics, and of course, it would be wonderful if certain things that come with age. Some things that come with age are not so welcome, but if you could turn off an unpleasant, a causal mutation, that would be fantastic. And we can't say that it is excluded, but we don't know at all about it.
What I think is true. No, I'm sorry. What I think happens is uveitis can reach a level and then become inactive. We've seen it in 45, 50-year-olds. Arthritis reaches a level and it kind of becomes stationary. But I don't know that that's the gene itself being turned off or some other factors that influence the actual outcome in the organ that is involved.
Exactly. Exactly. I think the manifestations can become less prominent, less intense with age, and we see in several conditions, but it might be more at the level of the immune system, that there are some regulations and calming mechanisms that turn up rather than at the genetic level. But it's a very interesting question. Would be wonderful.
Something to address. We could.
Yeah. Be wonderful to address. I think it would be great, Ilka, if you can bundle all the questions that were now put in the chat box and send them to both of us so we can think of them and also share them with our researchers, our young research teams who may be willing to address those towards the future.
And to the guidelines too. There may be...
And to the guidelines also, indeed.
We're working on.
That's a great idea.
Yeah.
Alrighty, this is for reals our last question. I want to be cognizant of your time that you're giving us today, but I have to ask this. I keep saying it's the last question, but this is a great one. And is there CRISPR research on NOD2? Are you familiar with that?
I'm familiar with CRISPR-R, and I absolutely, I wouldn't be surprised if there is something coming up, but I have not seen absolutely anything.
Yeah.
Yet.
I think a lot of us are curious, being a monogenetic disease and kind of some of the literature that's coming through as far as monogenetic diseases and this gene editing technology, and if we could potentially be a candidate for that.
You have to do a lot of editing and reach a lot of cells that are not that accessible to interventions. But yeah, eventually that may happen.
Yeah. Fabulous. Thank you so much. I actually think we got to every question, which is just amazing. And obviously the time that you gave us today we're all so grateful for. I also want to just do one more shout out for Dr. Rose and Wouters, because in the fall, we applied for a grant through the Chan Zuckerberg Foundation, as in like Mark Zuckerberg, and they have an initiative to support rare diseases. It was competitive funding and we weren't awarded the grant. We were really sad, but I want to just say the amount of time they put in to pursuing this grant to support their research related to Blau syndrome and how collaboratively we worked. It was just really encouraging to see. And I'm hoping that we can have further grant submissions. We have something strong developed. So we already have a great kind of map for how we can move forward in the future. But I wanted all of you to be aware. Again, that's one other piece in how they're supporting our community. And that was just recently within this fall was this large submission. Thank you so much for your time today. If anyone wants to type a quick thank you in the chat box, or you can turn your screen on and wave a hello. I know there's some people here that you guys are familiar with. Kathleen Mears is on here, Dr. Rose. So,
hi. Oh, Kathleen.
So we have a lot of fun individuals that we all.
It's a busy chat box.
I know. Yeah. Lots of great information. I'm going to put on here. Let me see. I'm going to try to, if anyone wants to unmute, you're welcome to do it and say a quick thank you. Other than that, we can.
Thanks very much. Thanks for the information. It was great.
Thank you for joining us. I'm glad you could make it.
Thank you. This is
I don't think I can hear it.
Yeah, thank you. And that's Catriona.
Cool.
She's from Ireland and a new member of our community. We actually just connected based on a post that we had when we were visiting Orla in Ireland. I wish we'd been able to meet up with you too.
Yeah, sorry, it's a pity. Next time, maybe.
Absolutely, absolutely. But we're excited you're here.
Well,
And I'm so glad you
bring one of your guitars whenever we meet.
bring the guitar. I love that.
I
Right.
can't play them. He's away playing.
Fabulous.
Oh, hi,
Yeah, I finally got it.
Kathleen.
Hi
Good.
guys.
Happy to see all these weights there. You need to be working out.
Great presentation. Thank you, everybody.
That's right.
Thank you, Troy.
Thank you so much. It was wonderful.
Thank you.
Thank you, Glenda. Okay, well, I'll go ahead and end it. I'll go ahead and end it here. And you all have the Blau Foundation. If you'd like to follow up with any questions, we're here for you. Thank you so much, Dr. Rose and Wouters.
Thank you, guys. Thank you.
Thank you
Bye.
very much. Have a nice day.
In your ear. I mean, he's slow. Yeah, he was tossing it around. I felt really bad. We need to get
Okay, that was good.